So, good morning, everyone. Today, Sanjam will be presenting the case and it will be moderated by Professor Sadiq, Sikora, Professor Rohit, Dama, and Professor Kishore. It's all yours, Sadiq, Kishore, and Rohit can take over now.
Yeah, good morning, Sanjam. Please go ahead and present. I think Dr. Kishore and Dr. Rohit are there, and we'll see how we can get through this case.
Good morning, sir. I am presenting a case of 59-year-old male, businessman by occupation, resident of West Bengal, who presented with the chief complaints of yellowish discoloration of eyes and urine in the past 2 months, loss of weight and appetite in the past 2 months, and episodic fever spikes in the past 1 month. History of presenting illness. Patient was apparently well 2 months back when he noticed a yellowish discoloration of eyes and urine, which has progressively deepened in intensity. In the next few days, he also noticed itching and clay-colored stools. He also complains of loss of weight and unintentional loss. He also complains of loss of appetite and unintentional loss of weight of about 5 kg, 69 to 64 kg, and also has generalized weakness since the past 2 months. 1 month later, he developed episodes of fever spikes, about 2 to 3 in number, which were not associated with chills and rigors and used to respond to over-the-counter drugs. So at this point, I would also like to know about whether the temperature was recorded and how much was the temperature, and if the jaundice was preceded by any prodromal symptoms. The patient has no history of abdominal pain, no history of nausea or vomiting, no history of hematemesis or melena, no history of early satiety, no history of abdominal distension, no history of altered bowel habits, no history of chronic drug abuse, no history of any previous blood transfusion, and no history of any alternative medicine intake, no history of respiratory discomfort, hemoptysis, bony pain, or back pain. At this point, sir, I'd also like to know about the urine output of the patient, as it has not been mentioned, and history of any altered sensorium or any history of or any features which were suggestive of in the history which was suggestive of hypersplenism. In the past history, the patient is known diabetic and is on regular medication and is controlled. There is no history of any previous surgeries, no history of any similar complaints in the past. For in the past history, I would also like to know about the onset of diabetes and whether it has onset in the recent time or it is a prolonged disease. In the personal history, the sleep was normal, the appetite was normal, there was no known addictions. He consumes a mixed diet. Bowel and bladder habits are normal and regular. And in family history, there was no significant family history. To summarize, 59-year-old male, known diabetic with controlled blood sugars, presented with painless progressive jaundice associated with cholestatic features with significant loss of weight and appetite, and with history of cholangitis.
Yeah. So, see, history has been given to you.
Yes.
So, from this, what do you think? Is it a good history that has been given to you? Or I know you mentioned a few points. So, how do you analyze this history?
Sir, regarding the symptom of jaundice, sir, I have been given the duration of the jaundice, whether it was noticed by himself or some other person, the intensity, how it has progressed, and how it is associated with the cholestatic features. So for jaundice symptoms, sir, the history is okay. And for the loss of appetite and weight also, they have in the history it has been mentioned about the amount of the weight which has been lost and which is significant. And about the fever spike, sir, I would like to know about the temperature if it would have been recorded, because whether it was a high grade fever or a low grade fever, because if it would have been if it would have been an infection or a viral hepatitis, then low grade fever would have been there, because it is not associated with chills or rigors.
So essentially, they've mentioned that there is low-grade fever. It responded to over-the-counter medicines. Maybe it's paracetamol. So we assume it is not very high grade.
Yes.
Maybe you could have asked if the patient got any antibiotics or something. That may have been important. So the jaundice per se, it's very typical of a obstructive jaundice. So
Yes, sir.
it's very typical. So that is very clear from the history. It is also short duration. So there have been no prior episodes, such episodes. So you can emphasize on that. So a short duration of obstructive jaundice, you should think of one, obviously a surgical obstructive cause, wherever it is, there is some obstruction to the biliary system. Second, whether there is intrahepatic cholestasis because of various causes. So that I appreciate you asked for prodromal symptoms and all, but apparently there were none. So
Okay.
the other usual cause apart from viral hepatitis is drugs and all that. So essentially we are looking at short duration obstructive jaundice
Jaundice
with,
with
with some
significant loss of
low-grade
weight.
cholangitis. Yeah, and significant loss of weight.
Loss of weight.
So what does it look like? I mean, from the history, what are you thinking of broadly?
So from the history point of view, sir, it is a obstructive jaundice with likely a malignant etiology because of its short duration and with significant loss of weight and appetite. And age of the patient is also in the fifth to sixth decade. So more likely the patient is having a painless progressive jaundice. So most common cause. First, I would like to keep, sir, the carcinoma head of pancreas, followed by periampullary carcinoma, then carcinoma gallbladder neck, and lower down hilar cholangiocarcinoma.
I mean, is it really too easy to differentiate the pathology from the history itself? Is it possible? We are looking at obstructive jaundice. Most likely, we are thinking malignancy. But I agree, these are the differentials. But I mean, can you really make out from the history that it is one over the other? Any particular reason for putting it in this order? Or
So for keeping the carcinoma head of
does it really matter for your further evaluation or treatment plans just from the
no,
history?
no, sir. So, based on the history, sir, it is more of a malignant etiology, we can say, sir, and we cannot rule out all the four differentials based on the history, sir.
Dr. Rohit, sir, Sadiq, sir, anything to add in the history part?
So Sanjam,
Yes, sir.
you mean to say if the fever, there's no fever with chills and rigors, it can't be cholangitis?
No, sir. Fever without chills and rigors can be cholangitis, sir.
Because you wanted to know the temperature. Also, the prodrome will come after jaundice.
Yes, sir. Prodromal symptoms will precede the jaundice, sir.
So if your fever came after 1 month later.
Yes, sir.
So I mean, when you're saying I want to figure out whether it is prodromal fever or a fever of cholangitis by the value of temperature, that may not be, it may not fit in. Why did you ask history of TB?
Sir, history of CB, sir.
That's
Actually,
TB you
I
mentioned.
asked the history of TB based on the investigation which was given to me in the examination findings, sir. Because in the respiratory findings, it had written that in the left infraclavicular region there was reduced air entry, sir. And
Okay.
they have written
It's
that there
a
was
direct questioning after examination. Right.
yes, sir.
Any other important past history which you would want to ask specifically, considering all the differential diagnosis which you have had?
Sir, I would also like to know if he had a similar complaint, if he had a complaint of any multiple episodes of like pain abdomen in the past, biliary colic pain.
Yeah. Yeah. So that if you wanted to ask something, that would be a pointed question to find out, because it may help, as Dr. Kishore asked, does it help the history to put any of these in order? So if patient had previous episodes of biliary colic and now presents with jaundice, you may consider them. Dr. Kishore asked that, is there any way you can make out by history this order? So can you at least give some symptoms which may help you make out this order?
So based on the symptoms, a carcinoma head of pancreas is the most common cause of malignant etiology for the painless progressive jaundice, in this decade. And in the periampullary carcinoma, sir, generally we would they rarely, but they present with the melena. The patient might give a history of eczema.
Periampullary will present with pain.
So periampullary does not present with pain, sir.
How about
Carcinoma head of,
cholangio?
yes, sir.
Hilar cholangio.
Hilar cholangio and periampullary generally do not present with pain, sir.
So all of them are painless progressive jaundice, except
Sir,
for gallbladder cancer.
yes, sir. And sir, neck of gallbladder also, sir, we can have painless jaundice until.
Really? What is typical of hilar cholangiocarcinoma?
Sir, the patient will generally give a history of severe pruritus and generally may give a history that a pruritus preceded the jaundice, sir.
So these are some of the indicators, you may use, as he says, that A, it is difficult and not very easy to put these in order based on the history, but some pointers may be there which you may use. And of course, it may not matter at the end of the day, except for importantly, whether it is benign versus malignant based on the history.
Yes, sir.
Also, the geography of the patient. Where is the patient from?
Sir, Eastern Belt, sir, West Bengal.
So maybe you will keep CAGB also on the back of your mind because
Yes,
it's
sir.
quite common, So
That is why, sir, kept it before hilar cholangiocarcinoma, sir.
it's fine. I'm just saying you should just keep these points in mind while you
Yes, sir.
analyze further. You'll have more information on examination and investigations, just to have your thought process streamlined. That's all.
Yes.
And honestly, I mean, it's not that neck gallbladder doesn't have pain because it's causing cystic duct obstruction. So you may have a mucocele and that may be causing pain. So it's not a gimme that neck gallbladder will not have pain.
Okay, sir.
All right, let's go ahead.
Examination, general physical examination. Patient is conscious, cooperative, well oriented to time, place, and person. He's a moderately built and nourished. BMI is 22.6. ECOG status 1. Breath holding time was 42 seconds. In vitals, the pulse rate is 96 per minute. BP is 120/70. Respiratory rate 14 per minute. And temperature was afebrile. The icterus is present. No pallor, cyanosis, lymphadenopathy, and or edema. No visible scratch marks. No signs of liver failure, and no signs of enlarged left supraclavicular nodes. Per abdominal examination, abdomen is flat and umbilicus is central in position. All quadrants move correspondingly with respiration. No sinuses, dilated vein, visible peristalsis, pulsation scars were seen. No renal angle fullness, hernial orifices, and external genitalia were normal. At this point, I would like to ask if on inspection any visible lump was present. Palpation, abdomen was soft and non-tender, liver and spleen are not palpable, and there was no palpable mass. In percussion, the upper border of liver dullness is noted in the fifth intercostal space in the right mid-clavicular line. Liver span is 13 centimeter in the right mid-clavicular line, and the flanks are tympanic. In auscultation, there were normal bowel sounds heard. In digital rectal examination, the sphincter tone was normal. There was no palpable growth, and the glove was stained with the clay-colored stools. In respiratory system, the patient had a reduced air entry noted in the right infraclavicular area. Normal vesicular breath sounds were heard in the rest of the auscultatory area. Dull note on percussion of the right infraclavicular space, and there is no crepitation or other added sounds. CVS, S1, S2 were normal. There were no murmurs. And in CNS, the patient had a higher mental functions normal and no focal neurological deficits. To summarize, the 59-year-old male, known diabetic with controlled blood sugars, presented with painless progressive jaundice associated with cholestatic features with significant loss of weight appetite and with history of cholangitis. On examination, ECOG 1, icteric with no palpable mass or gallbladder and with a reduced air entry in the right infraclavicular area. Might be a case of old pulmonary TB. And as per my history and examination, my differential diagnosis include first a hilar cholangiocarcinoma, followed by carcinoma head of pancreas, carcinoma gallbladder neck, and periampullary carcinoma.
Excuse me, there, the respiratory findings are actually normal. There is a typing error here. I'm
Okay.
sorry.
Okay. So we can disregard that. I mean, it's good that the examination was contributory for two things: one positive finding of icterus,
Yes.
and one negative finding of not having a palpable gallbladder, which you pointed out, which is very good. So, see, icterus, you should also try to find out whether it was deep or not, so that you'll have some semi-quantification for that. Apart from
Yes.
that, what are the implications of a palpable gallbladder in this sort of situation when you're thinking of a biliary malignancy? What are the implications of a palpable gallbladder?
Sir, if we are able to palpate the gallbladder in a malignant etiology, then the block is in the distal part of the CBD, sir, or in the head, distal to the insertion of the cystic duct. If there is a block, which might include a periampullary carcinoma, head of pancreas, or distal cholangiocarcinoma, then we might be able to palpate gallbladder. And if there
Any
is
other
no
situation where it may be palpable?
um, sir, if it is a mid CBD cholangio, if it is the cholangiocarcinoma just at the insertion of the cystic duct or in the then also we might be able to palpate the gallbladder, sir, due to
In addition, anything else?
sir, if
Yeah, if it's a carcinoma neck of gallbladder also, so that also
yes,
you mentioned. So if it is involving the cystic duct, even then your gallbladder will be palpable. The other thing is, even in a hilar cholangio, although it is supposed to be high up, sometimes the bile duct cancers can grow intraductally. And like you said, you should give an anatomical possibility first, then the pathology. So if there is obstruction to the cystic duct insertion, like you correctly said, only then you expect the gallbladder to be palpable. So that can include a variety of these conditions. Any way to differentiate whether it's a gallbladder cancer or a periampullary cancer, or other? How do you differentiate between a gallbladder cancer and other cancers causing a palpable gallbladder?
sir, in the gallbladder cancer, based on the history, so the patient might give us
Only on examination. Only on examination. So if you find that, if you find the mass
mass.
palpable instead of a distended gallbladder, then you might be inclined to think it is a gallbladder cancer. That is one way to find out. But there is a caveat, like sir already mentioned, if there is an obstruction to the neck and if there's a mucosal, you may just find a tense swelling there.
Yes,
So it really depends. If you really find a mass when you put your hand there, and if you find the gallbladder is palpable and it's replaced by a mass, you would think of a CAGB. If it is a distended gallbladder, you have to think whether there is a superimposed stone disease or a mucosal or even an empyema in the presence of CAGB. Or if it is just a smooth, non-tender gallbladder, in which case you can think it is a periampullary or a CA head pancreas. This is just traditional teaching. See, there are a lot of caveats to all of these things. But when I asked you what are the implications of a palpable gallbladder, you can say all these things. All right.
So, Sanjam,
yes, sir.
you said, you were given that liver span is so much. So, what is it? How does it help? And what is the normal liver span?
So the normal liver span
Yes,
is
it is enlarged,
yes.
normal.
So here it is a normal liver span. So 12 to 16 centimeters is considered as a normal liver span, sir, in an adult.
Okay. Okay. And why you change the order now after the history?
So because, sir,
After the examination, sorry.
yes, sir. Based on the examination findings, sir, the gallbladder was not palpable. So the block is The block may be high chances the block is above the insertion of the cystic duct. So the probability of a hilar cholangiocarcinoma is more likely as compared to the other malignancies, which might include carcinoma head of pancreas, carcinoma, gallbladder, neck, or periampullary, sir.
So in all, if you don't have a gallbladder palpable, you rule out periampullary and carcinoma pancreas.
So no, sir, we cannot rule out. There are chances that the gallbladder might be palpable in these conditions, but uh, based on the examination, it is likely that in the hilar cholangiocarcinoma we might not be able to. Most of the cases we might be able. We will not be able
Basically, my question is it that significant? The absence of palpable gallbladder makes you start thinking that, oh, it's not this and it's this one way or the other. What I mean to say is it enough to change your initial order of differential diagnosis?
Sir, I changed the initial order of my diagnosis because of the likelihood of based on the likelihood of the palpable gallbladder in these conditions. So that was the only reason.
Yeah, so just I wanted to highlight that it is not necessary. So we know that Courvoisier's law is only possible in 50% or so. So just the mere absence of a palpable gallbladder need not change the whole differential diagnosis order.
Yes.
The logic is right, but not necessarily true in a clinical scenario. Okay.
So now you have all these things, history and examination is done.
Yes.
As it usually happens, patient comes with a lot of tests done outside, he doesn't walk into a tertiary center with, first time. So suppose he has some tests and you were to choose 3 tests as the initial things to screen his file. So what would you look at? Just 3 things which will help you plan further.
So based on the for 3 things, sir, first in the blood investigations, I like to know the CBC and the LFT of the patient.
Okay.
So
And
as the
why
third,
also?
sir, in CBC, in the complete blood count, I would like to see the total leukocyte count. Because the patient already had fever, to rule out if the patient is having cholangitis, and in LFT, I would like to see the total mainly total and direct bilirubin and the ALP of the ALP and the INR of the patient, sir.
Why also?
Yes, sir.
Why also you should say the implications of looking at suppose you find elevated bilirubin and you said alkaline phosphatase, you expected it will be elevated, isn't it? Anyway, we can open the LFT in the meantime. So you can tell us how you interpret this.
Sir, it is the total bilirubin is 13 and direct is 8. So it is a direct hyperbilirubinemia, and the ALP is also 284, which is on the higher side. So we are suspecting a surgically obstructive jaundice, and INR is within normal limit, 1.08. So if the complete blood count, the TLC is also normal, so we can rule out the patient is in cholangitis at this moment, and we can go ahead with the investigation, sir.
But what about the other things? They are also important. The albumin is very important, isn't it?
Albumin mainly for the nutritional status of the patient, sir, to evaluate the nutritional status.
Also, it has a major implication for prognosis after any intervention you do. People with low albumin fare badly. We all know that, isn't it? So this is a low normal albumin. So 3.5 is the upper limit of normal in most labs. Normally, people would have 4 or so. 3.6 is just so. And also these AST, ALT also you should not disregard. So they are also high. They're about 5 times normal.
Transaminitis.
So they're 5 times normal, isn't it? So what does that mean to you?
So there might be some sinusoidal injury because of the high bilirubin, which bile salts can result in the injury of the hepatocyte, which might result in increasing the AST and the ALT because of the cholestasis.
Your patient has fever, isn't it?
Sir, actually, sir, it is not provided whether at this given moment the patient was febrile. So that is why I wanted to know the total
That doesn't
count.
matter. You
Whether
have
he's febrile or not right now, but if he has episodes of fever, what does it indicate? You have made it in your diagnosis.
So patient is
Somebody
having
you told that patient has cholangitis.
cholangitis. Yes, sir.
So does this corroborate that, or is it doesn't matter?
Yes, sir. It supports the diagnosis of cholangitis, sir, in the patient, sir.
yeah.
It just supports the fact that there is inflammation and the fact that patient had fever with jaundice with a raised transaminase. It just corroborates that fact, isn't it?
Yes, sir.
So you have to, when you look at the LFT, these are the things. One is the level of jaundice, level of hyperbilirubinemia. See the ASTLT, see if there's any cholangitis. You're looking at synthetic function, albumin and INR. So you can get this much information with LFT. The first one you said is CBC, that I'm quite happy you said mainly to rule out cholangitis. You'll also know your hemoglobin level. What is the third thing that you want to see?
Sir, I'd like to order a ultrasound for the patient, sir, hepatobiliary system, sir.
Can we see the ultrasound? So just
Look
read
at-
it and then interpret it. Don't read the whole thing. Just tell how you interpret this ultrasound.
Yes, sir. Sir, first, sir, the liver is mildly enlarged, but it is normal in aqueous texture. And first finding is there is a mild to moderate bilobar IHBRD, but the proximal sir,
Interpret.
inter,
Interpret.
yes, sir. Since the GB is normal in size, so the level of the block we can suspect is above the insertion of the cystic duct, because the patient is also having the bilateral IHBRD, and GB is also normal, so gallbladder can be ruled out. And the in pancreas also, so there was no findings. Rest also there was no free fluid, no ascites or lymphadenopathy. In here, sir, I would also like to know whether there was any other lesions which were visualized in the liver on the ultrasound.
Let's assume they weren't. Not seen.
Yes, sir.
Not seen.
Okay, sir. Based on these findings, sir, the patient is having patient is having a hilar block with the bilateral IHBRD, suggestive of surgically obstructive jaundice, sir.
So
Kishore, just a minute.
Yeah.
See, I don't like this term surgical obstructive jaundice. This was an old term we used to use. Now you may have a extrahepatic anatomical block due to any, and it may still not be surgically treated, isn't it? So you have very many conditions which you may not treat surgically, and for various reasons you may not have to, a patient may not be a suitable candidate for surgery. So just all the time saying surgical obstructive jaundice is not a good term in my opinion. What do you think, Kishore?
yeah, I think it's an obsolete term. It was based in medical history. I mean, so I think you can just say obstructive jaundice. And
Extrahepatic or intrahepatic you can make, or so the main question is you chose these three and correctly you chose, and from ultrasound in interpretive manner what information you wanted, and did you get that or not?
So first, so from the ultrasound, first I wanted to know about the level of the block.
Excellent.
And
So did you
second,
got that?
So vaguely, sir, I can tell the level of the block because the
Why
proximal
vaguely?
is, sir, it is a perihepatic. It is not intrahepatic. It is extrahepatic, but it is above the insertion of the cystic duct. So it is a hilar block, sir.
So yeah, so you got the level of block.
Yes, sir.
Then what else you wanted to know?
Second, sir, I wanted to know about the intrahepatical biliary radicals, whether they are dilated or non-dilated.
That's how you knew where the block is, isn't it?
Yes, sir.
Based on the dilatation and the extent and the level of dilatation. So that's the same thing, level of block.
Third, I wanted to know, sir, there were any other lesions which were seen in the liver, sir. And fourth, if there was any lymphoedema, if there was any evidence of ascites on the ultrasound. And fifth, if they were able to see any lymph nodes, regional lymph nodes on the ultrasound or not, sir.
The second is level of block, and second is whether the etiology of block can be identified or not. So that may not be there all the time, but that is also another purpose of doing an ultrasound. So you may see a big head mass, you may see a mass in the gallbladder. So if you see that, it is evident. So level, etiology, nature, benign or malignant, and then if it is malignant, as is your consideration with history and examination, then whether there is any evidence of metastasis, right? So you mentioned all of this, but you need to be able to clearly communicate that these are the 4-5 things I'm looking at.
Yes, sir.
So based on these 3 tests which you wanted, CBC you saw, right? You didn't?
Yes, sir.
Yeah.
In complete blood count, HB is 12.3. Total leukocyte counts is 10,900 and platelets is 2.39 lakhs, sir. It is within normal range, sir.
So now you got these 3 tests. What is your diagnosis?
Um, so based on the history and the initial investigations, sir, I'd like to keep again, sir, the Hilar extrahepatic mainly perihilar cholangiocarcinoma as my first diagnosis, and uh, and uh, and I can also consider CA head of pancreas or periampullary carcinoma as a second and third diagnosis. But since the gallbladder is normal, and I would like to keep CAGB neck as a lower down, sir.
But why would you keep CA head and periampullary now after this ultrasound?
So because sir, the ultrasound is not a good modality to evaluate the pancreas, and they have not commented upon the distal CBD, sir, in the ultrasound, sir.
So if it was dilated, they would have seen it, isn't it?
They have committed that the CBD is 5 millimeters. So in the presence of jaundice of 13 and significant IHBRD, you would expect the extrahepatic biliary tree to be dilated, and we believe that the sonologists are good. So in that situation, I think you can rule out distal obstruction. It's probably a proximal hilar obstruction, isn't it? They've clearly commented that the bile duct is 5 millimeters, gallbladder is normal. So we assume the distal CBD is normal, but there is still significant IHBRD in the face of a bilirubin of 13. So you would think it is a hilar obstruction.
Yes.
So you just have to interpret what you have. You can revise it later if you have fresh findings. So what would you do now?
So now I would like to plan a triphasic CT for the patient, but before that, I'd like to know the kidney function test for the patient to check for the creatinine, sir.
Let's assume it's normal. Creatinine is normal.
Then, sir, I would.
Any other blood tests you want to do?
Sir, at this point, we can also do a tumor marker, sir. CA99 can be done, but bilirubin is
Can we see
very
the
high.
CA99?
It was 9.7, sir.
How do you interpret this?
So CA99 is within normal range, sir, even for this high bilirubin. So it is a non-secretory.
Can you elaborate what you mean by that?
So generally, the CA99 is secreted by the biliary and the pancreatic epithelium, and if the carcinoma is a non-secretory type, then there are chances the CA99 might be within a normal range, sir.
So it's not the carcinoma. Some certain percentage.
Some cholangitis, yes, sir. Even in the cholangitis or with the choledocholithiasis, the patient might have high CA99, sir, or any inflammatory condition, sir.
So here we are talking about a low CA99 and why it is low, despite you suspecting malignancy and despite the presence of high jaundice and despite the presence of low-grade cholangitis. So it's counterintuitive, isn't it? What you said is right. So it's not the cancer, but a certain proportion of the population, say 10-15%, they do not secrete. It's a carbohydrate antigen. So not all of the population secretes this antigen. So even 10 to 15% of people may not secrete this and may have a normal CA99 despite all these things being present. So that should be your answer.
Yes, sir.
Lewis antigen negative.
Yes. So the blood group with the same carbohydrate antigen.
So what next?
Sir, I'd like to order a triphasic CT scan for the patient, sir. It will also include the chest and both chest and the abdomen, sir.
Okay. While we are at this, I'll ask a classic question. It's always asked in exams. Why not a MRI or a contrast MR over a CT, especially when you're considering a proximal block?
So contrast MR is a better modality as compared to CT scan for evaluating the hilar block, but based on the easy availability and the cost effectiveness and the easy interpretation by the surgeons. So I'd like to do a triphasic CT, and for the hilar block, I'll like to add MRCP, sir, instead of CMRI if I'm able to get what I want on
How is
CT.
it cost effective? Doing two tests.
So we are as a surgeon, I'm bit more comfortable with
Suppose patient
well,
comes to your center, what will you do? Suppose it's a hilar cholangio. You're thinking as your first possibility. What is the accepted protocol?
so triphasic CT abdomen and chest with combined with the MRCP, sir.
Okay, I'll accept that, but you should tell us the reasons why you want to do that. But you didn't mention that the first time when you said, you just said triphasic CT. Why didn't you mention MRCP then? But anyway, I'll accept your second answer, but you should tell why also.
Sir, in triphasic CT, sir, we'll be able to generally stage the disease, know about the vascular involvement, the lymph node status, mainly the TNM of the tumor, but we will not be able to assess the longitudinal length of the block, and it will be better assessed on the MRCP, sir, about the involvement of whether there is involvement of a primary confluence or the secondary confluence is involved or not. That is the reason I'd like to do add MRCP to the triphasic CT, sir.
Yeah, so you should say CT is generally to assess vascular involvement, especially in a hilar cholangio. You would think the arteries may be involved, portal vein may be involved. You want to see it properly. So, and MR will tell you the extent of ductal involvement, intraductal involvement, because then you should plan your type of resection based on that. So you would do both, but there are centers who are very, very comfortable with doing it. So the same information you can get with a contrast MR. If you do a contrast MRI, you get everything. So
Yes, sir.
I think, sir, what are your comments on this? And Dr. Rohit also.
I agree. See, we can't now keep on harping about I'm more comfortable or surgeons are more comfortable. Now, the method of evaluating a radiological investigation is sitting on the console with the radiologist and having a look at that. And a contrast MR, and you add to that the diffusion weighted sequences, it all add up much more information in terms of providing the extent of disease, vascular involvement, and the nature of the disease also. So I think you can't escape from just by saying we are more comfortable with doing. But as Kishore said, it depends on the what practices you follow in each center. And if you have to do two tests, then you have to combine the contrast triple phase CT along with a MRCP conventional so as to get all the information. And one has to think seriously regarding getting one test done and getting all the information.
Yes.
Would you do a PET scan in this situation?
PET scan, sir, in the hilar cholangiocarcinoma, sir, there are it is not FDG gave it, and the sensitivity is also around 70 to 80% only. And if we want to, if on CT and MRCP, if we find the tumor to be unresectable and we want to rule out the metastasis, then we can add the PET CT to our investigation. Or the tumor is a locally advanced and we are planning for a new adjuvant therapy, then we can do a PET CT to rule out any metastasis in the other parts.
What do you mean? What situation Hilar cholangio you would consider locally advanced and a candidate for a new adjuvant?
Uh, Sir, if we are in the future, if it is unresectable, but if it is a small tumor and we are planning for a liver transplant in future and is a candidate for liver transplant, then we can consider the new adjuvant therapy for the patient. So,
So you're talking in the context of transplant. That is a totally different thing. What you're talking is.
But
Yeah.
Sanjam, see,
Yes, sir.
whenever a question is asked, first you have to give the answer. You can't start after what all you said. I didn't understand whether you'll do or not do a PET CT. So first
Sir,
you
I'll
have
not.
to say yes, I will do, or no, I will not do, and then give the reason why you will not do. You understand? So always remember this. First, give an answer. So will you
Sir,
do
I'll,
or not do?
sir, I will not do the PET CT scan in this case, sir.
Okay, okay, and why not? Then you give the answer.
So because I will not be getting any additional information after doing a triphasic CT and MR, and the sensitivity is also low of in the hilar cholangio, the PET CT sensitivity is also low, sir. 70 to 80% only, sir.
Much lower than that. It's not 70 to 80. 70 to 80 is good. But the likelihood of metastasis is less. The pickup rate on PET CT or uptake is also not very consistent and high. So in considering all this, it is not a standard investigation in the workup of patients with a hilar cholangiocarcinoma. But if you find something else on CT scan or so when you're doing it, then you may be sort of forced, or you may plan to do a PET CT based on the findings of CT scan or whatever you see on the imaging after, whatever you have ordered at that time.
Yes, sir.
Also, the level of CA19-9 may have a bearing on whether you would choose to do a PET CT or not. Sometimes it is very high, considerably high in thousands, and therein the likelihood of metastasis is high in that situation. And you may choose in that scenario to do a PET CT upfront rather than later.
Yes,
And
sir.
sometimes you can combine PET CT with a triple phase contrast CT, thereby avoiding a CT and then a PET CT.
Yes, sir.
Can we have a look at the cross-sectional images, the CT and
Rohit, any comments, Rohit, till now? Okay, let's see the scan.
She was evaluated outside, so we have MR, which was done before imaging. MR.
Okay. You can tell us grossly what you see.
Yes,
And
sir.
there are challenges
Yep.
in interpreting it distantly, but grossly
Yes,
what
sir.
you
Grossly, sir, I am able to in this cancer, there is a bilateral IHBRT, and but there is a thickening which is present above the primary confluencer, and the primary confluence is not getting formed, and it is a little bit extending towards the left side also, sir. Okay. To the right side, sorry. And the primary confluence is not formed, and even the secondary confluence is not getting formed, sir. A right secondary confluence is not getting formed.
Is it possible to show one single shot image of the MRCP? That will give us some idea if it is there. Yeah, you can rotate it if possible. Yeah, this should be fine. Yeah, that's great. Okay, so what do you
Yes.
find?
So here we can see the left ductal system is dilated, but the right is also dilated, but the primary confluence is not getting formed, and even the right secondary confluence is not getting formed, sir, in this thick slab, sir.
Why do you say that? I mean,
What
right.
do you mean right secondary means what?
So the right anterior, so this right anterior and the right posterior sectoral duct, sir. I'm not able to see a common channel.
There is a big common channel there. You can see the entire right hepatic duct there.
At least in this.
Yes.
Can you
Yes, sir.
rotate a little more?
So what type of block is this?
So the primary confluence is involved. It is a type 2 block, sir, but it is not extending into the any of the right or the left side, sir. Mainly the primary confluence is involved, and it is not getting formed, sir.
Okay, maybe type 2 or type 3. Because
So if you look at the axial sections, you will see whether it is extending up into the right or not.
So in axial, sir, it was extending towards the right, sir. But in this, sir, I was not able to. Yes.
So that's the
Yes.
limitation.
Yes, sir. In axial, it is extending to the right. So based on that, type 3A blocks.
Okay, agree.
Go down a little bit on this axial section. Go down a little bit on this axial section.
Yes, sir. Yes, sir.
Don't have control.
Yes, sir. Now I have control, sir.
Go down a little bit more. थोड़ा ऊपर अब थोड़ा हाँ that's अभी देखो
Yes, sir.
कैसे कर रहे हैं.
So yeah, we agree it's type 3A. So CT do we have to see vascular involvement?
This CT was done after stenting, sir.
Okay, so
After?
stenting. Okay. So in that case, don't open it for now. So we'll ask one question. If you have to choose ERCP versus PTBD for preoperative biliary drainage, what would you use? First of all, in this case, would you use or not, and why? If you use, second question, what will you choose? ERCP versus PTBD and why?
Sir, in this case, sir, I'd like to go for the preoperative biliary drainage if I'm planning the surgery, because the patient is having a high bilirubin, and most likely the patient will require a right or right extended hepatectomy, sir, in this case, based on the CT evaluation. So I would like to go for the ERCP or the PTBD drainage. So, and in this case, sir,
You have any threshold of
अभी
bilirubin?
तो how you have made all these decisions? Do you know vascular anatomy?
So that is what, sir. If it is resectable, sir. If it is resectable,
Yes,
and if I'm planning for a.
You have to say that I don't know the plan till I get all the information.
Yes,
Isn't it?
This patient is already stented, it seems, sir, in the CT. So that's why I asked him if I didn't want
But
to.
I thought it was, let's just have a look at it.
Yes, yes.
In CT, what all are you going to see?
Sir, in CT, sir, I'd like to
Vascular involvement.
vascular involvement, if in lymph nodes or any signs of any metastasis and ascites.
Anything else? Which for all HPB surgeries, when you do and evaluate, you need to look at those things.
Sir, if the arterial anatomy of the
Yes, that's very important.
yes,
In any of these surgeries that you undertake, HPB, because of the variations in anatomy, in vascular anatomy, should always make it a point to assess the vascular anatomy and its variations. And that should be an important point of assessment. All right, is it moving or not? Can you quickly see? Grossly vein and artery, I thought it was reasonably good.
You can see both in this. It's a delayed arterial phase. You can see both portal and arterial. So you quickly
Yes.
tell us what you're seeing.
So portal vein is not involved, sir. There is no contour irregularity or no tumor thrombus present in the either main portal vein, right portal vein, or the left portal vein, sir.
Okay.
So right hepatic artery, I'm here, sir. No, it is okay.
Point it out. Just keep that section there. Come down a bit.
Yes, sir.
Down. Come down a bit.
Come down where the artery is.
Little up. Yeah, just stop there.
Yes,
Stop
yes.
there. Point the
Yes,
right hepatic artery.
Yes, sir.
Okay. Where is the bile duct?
Sir, here.
What is the white thing inside?
So stent which is
That's
present in the
the
bile.
So, what is the relation of the right hepatic artery to the bile duct? Is there some soft tissue around it, or it is completely clear?
Sir, it is posterior to the right hepatic artery, goes posterior to the bile duct, sir.
Yes, that's right. But what I'm saying is, you can't say it's entirely free because
Yes, sir.
it's very close to the bile duct, and it seems like there is some soft tissue around it, isn't it? Especially a little distally. Also, see, there's some
Yes, sir.
irregularity there.
Uh,
Not distal, yeah, up there. Before
Yes,
this,
sir.
one cut down. See there. Just keep this. You can see a little bit of a irregularity there. It's probably close proximity to the tumor. It's not occluded, but it's probably very close. What about the other artery? You should see the segment 4 artery separately and the 2-3 arteries also.
Okay, sir.
Where is the
Sir, it is a
segment 4 artery?
replaced left hepatic artery.
Okay. Where is the segment 4 coming from? Is it coming from the same artery or it's coming separately from the CHA?
One second, sir.
No, go back and go slowly. There.
Yes, sir. Segment 4 artery. One second.
Just follow it
Fix
down.
it.
From the fissure, you follow it down.
It is not coming from the left hepatic artery, sir. It is.
Yeah.
It is
Follow
coming from the right hepatic artery.
Correct.
Yeah.
So it's coming separately. So it's 2-3 which is replaced on the left gastric artery. Segment 4 is coming separately from the common artery. That's important. If you plan surgery, you want to preserve the vascularity of 4. So you should take the right hepatic artery distal to the origin of the segment 4 artery. Anyway, so arterial anatomy is okay, portal vein anatomy is okay. There is no distant metastasis. So what else do you want to know from the CT?
Sir, I'd like to request the radiologist for the CT volumetry of the patient also, because I might be planning for the right trisectionectomy, because the segment 4 artery is also rising from the right hepatic artery, and there might be chances that I'll not be able to preserve the
No,
segment 4
it
artery.
is very far away. The origin of segment 4 is very far. You would be able to preserve it. That's not a problem. That's not the reason why you'll do a trisectionectomy in this case, isn't it? The reason for trisectionectomy is to get a margin, not
Margin.
for. You'll probably you'll do something else, not exactly a trisectionectomy, but something else. But in addition, you know that there is no cholangitic abscesses you're seeing on the CT. That's another extra information you'll get. And you would want to do a volumetry.
Yes,
Okay.
sir.
So volumetry, can we see data if it is there? So while it is loading, you tell us, in this case, what was done, ERCP or PTBD? What has been done?
So the ERCP stenting has been done, sir.
So what would your choice be, ERCP versus PTBD, and why?
Sir, I'd like to do a ERCP stenting of the future liver remnant, in this case, the left lobe, in left duct, and because it will have the internal drainage of the bile and the other complications of the PTPD we can avoid, sir. But if the patient, well, a patient also does not have a cholangitis, sir, so we can drain the FLR and then we can wait.
Okay.
If the
What does the literature say on ERCP versus PTBD for hilar cholangiocarcinoma? And what is practiced in your center? These two things you tell us.
So the literature shows a comparable data between the PTPD and the ERCP, sir. Both have the pros and cons, and because in the ERCP we might be have to insert the multiple stents, and the multiple time intervention might be needed with the ERCP due to the stent block. But it will also have the added advantage. It will also have the advantage of internal drainage of the bile, which is not present in the PTPD, and also data has shown in PTPD there are 5% chances of tumor seedling, which is present. In our center, sir, we practice ERCP stenting. First, we try for the ERCP stenting. If the ERCP stenting is not feasible, then we go for the PTPD to drain the FLR of the patients.
Okay, fair enough. It depends on local expertise, and also it depends on the type of block. Generally, see, if it's a type 4 block where the ducts are all extensively separated, you would need a very experienced endoscopist to place a stent across the block. You should not target ducts which are, going to be in the resected side, because once you inject dye, and if dye goes into a separated system, they'll land up with cholangitis, and it's very difficult to treat. It will delay surgery, increases morbidity. So if it is only a single stent that is needed, like in this case, ERCP may still be okay. It has the advantages of internal drainage. But if multiple stents are placed, there is enough data to show that ERCP with multiple stent insertions has a very high risk of cholangitis. And there is a finite risk of pancreatitis also, that is not there with PTBD. The problem with PTBD, of course, is it's a bother of an external drainage. You can make it internal-external, but still it is a problem of tube slippage and all that is there. But generally, many centers follow a PTBD for a high hilar obstruction. Like if it's a type 4, I would think that many people would still prefer a PTBD. Data is, there is only one RCT, but then it's not a very good study. Okay. So,
Yes.
you have to read up a little more on this. The FLR, can we see the volumetry? Just comment on this. What is your comment on this?
So the total liver volume 1500, and the future liver remnant left lobe with MHV is 657. So it is adequate.
So which type of resection you do based on this?
So if we are planning
to do an extended right appendectomy?
So based on this volumetry, we will not be doing the extended right sir, because the FLR will be less than 20%, 18.8% of the future liver remnant, sir. Less than 20. So we will not be doing right trisectionectomy at this stage, sir, for the patient, sir.
So that means in that segment 4 artery, you have to be very careful, aware where it is coming and not coming through the segment of vessel which is involved with tumor, isn't it?
Yes.
You have to be absolutely sure. So you need to see good images which would ensure, as we saw in that, it is coming and arising much lower from the right hepatic artery. So it looks okay. But considering this, that you can't take a decision on the table that you want to sacrifice that, right? And what other you would do right appendectomy with or without MHV? Which one you would do?
So I'll do right hepatectomy, well, I'll preserve left lobe with MHV, sir.
Yeah, because in this hilar cholangiocarcinoma, in all likelihoods, you should be okay to preserve that unless in the initial part, that right anterior extension of the tumor is encroaching onto the middle hepatic vein. Okay.
Most of the times for a hilar cholangio, you'll plan a modified extended right hepatectomy, isn't it? So you'll do a right hepatectomy with a little bit of segment 4B. 4A you can save entirely. Because it's in the hilum, the tumor, you have to get
Yes,
to the left of the tumor before you cut the duct, which means that you will have to transect a little bit of 4B to get on top of that duct. So you'll have to take a little bit of segment 4B. So you'll actually have to talk to the radiologist and ask them to tell you individual segmental volumes of 4A and 4B. You have to sit down at the console and see what is the volume of 4B, what is the volume of 4A, and how much are you actually going to save. So 2-3 is obviously very small. You will see what is the volume of 4. You will try to save most of 4, but a little bit of 4B you will have to sacrifice. Obviously, you will save the left portal vein, so there is inflow. You will save both the arteries, segment 2-3 artery and 4 artery. So there is good inflow and outflow. I think the upper part of the middle hepatic vein you will definitely be able to save. So there is good outflow. So you will have a good remnant, but obviously you are concerned about the volume of the remnant. In a cholestatic liver, so you are going to how much volume do you want as a FLR at least? Suppose you do this preoperative biliary drainage and the bilirubin has come down to 3, you say, and you're ready for surgery, but how much is the FLR you would accept?
Sir, it will be more, if it is a normal liver, more than 20%, but if it is cholestatic, I like to keep it more than 30%, sir.
Yeah, I would think at least 35% would be, safe. Because you don't know how they'll behave. He's diabetic also. There may be some element of steatosis or NASH. So, so that's the other thing you have to look in the CT. It looked okay. But NASH with cholestasis is a very, very bad combination for regeneration. They don't regenerate well. They'll go into post-hepatectomy liver failure. So you should be absolutely certain of the volumes and that you're having at least 35%. If not, I would even think of a PVE.
Yes, sir.
So these things you should come out before you make the plan. So you can't base your resection by looking at the volumes. You should plan your resections and then look at the volumes. You are doing it vice versa. You get my point?
Yes, sir.
Okay, I think we're at 9. Good. Let's have some other comments and this thing. Rohit, you have not said anything. You want to make a comment on his presentation and anything else? You're muted. You're muted. Unmute yourself. Muted.
Rohit, you're muted. Unmute.
Okay. While he unmutes, Dr. Kapoor is there. I'm sure Dr. Kapoor would have some pearls for Sanjam.
Morning, Sadiq. Good morning, everyone.
Morning, sir.
So for all the students, just to repeat, when you have a patient with jaundice, first you have to show and prove based on history and examination that it is obstructive jaundice. Second, you have to say whether it is benign or malignant. Now, if you have said that it is malignant surgical, or I wouldn't say surgical, obstructive jaundice, the most important differentiating feature is pain. So if there is pain, the first possibility which you should mention after history is head of the pancreas. And the characteristic presentation would be epigastric pancreatic pain with all the features of pancreatic pain, which would be present in about 60 to 75% of patients with head of pancreas. So which means that even head of pancreas can be painless. And the supporting symptoms could be symptoms of gastric outlet obstruction, early satiety, postprandial fullness, inability to take a full meal, nausea, and then frank vomiting. There may be history of chronic pancreatitis, but in the past history, you should mention that will tell the examiner that you are aware that it could be an underlying chronic pancreatitis, which has now led to a malignancy in the head of the pancreas. And on examination, you will have a distended gallbladder. And in a very thin-built patient with lax muscles, a pancreatic mass may be palpable. So that is the characteristic presentation of head of pancreas. Gallbladder cancer, the patient will have a right hypochondriac pain, which is dull continuous, which is present in about 50 to 60% of patients who are clinically suspected to be having gallbladder cancer. So less than head pancreas. There may be history of symptomatic gallstones in the past. So again, in the past history, you should mention whether such a history is present or not. And on examination, a GB mass is palpable, which is different from a distended gallbladder. If you have painless malignant surgical obstructive jaundice, then statistically speaking, periampullary carcinoma, where very few patients may give the characteristics of waxing and waning. Again, it is more important that you mention it, that there is no history of waxing and waning, which, if it is present, may be associated with an episode of melena. And if you have a young patient in whom you are making a diagnosis of periampullary carcinoma, you should clearly, specifically, separately mention no history of flesh bleeding per rectum to suggest a polyposis disorder. The patient with periampullary carcinoma is usually painless, but as Sadiq said, the pain of distended gallbladder may be present, which is more like a discomfort. Hilar cholangiocarcinoma again is painless, and very few patients, rarely, may have the characteristics of pruritus coming before jaundice. The gallbladder obviously is not palpable. These patients may have, again, you have to mention in the past history of long-standing cholangitis, not cholangitis now because of malignancy, but long-standing cholangitis suggestive of a pre-existing choledochal cyst and a rare possibility of primary sclerosing cholangitis. And in the past history, you may mention no history suggestive of inflammatory bowel disease. You should remember that patients with pancreatic cancer in the uncinate body and tail will not have jaundice or may not have jaundice, but they will have only pain and anorexia and weight loss. Also, you should remember that uncommonly or rarely, a CBD stone may present as painless progressive jaundice if the stone is impacted at the lower end. But you should not make a clinical diagnosis of CBD stone in a painless progressive jaundice. The question which Dr. Sadiq asked, you should have answered that what would you see or how does ultrasound help? First, it confirms that it is surgical obstructive jaundice, because if 2-3 days after the onset of jaundice, IHBRD is not present, it is not obstructive jaundice. Then it tells you the level of block. So you see IHBRD, you see the confluence, you see the proximal duct, the common hepatic duct, which radiologists always call proximal CBD. You see the CBD and the extent of its dilatation till lower end, and you see the pancreatic duct. In hilar cholangiocarcinoma, you will have IHBRD, but confluence is not formed. In gallbladder neck cancer, you will see IHBRD, confluence forming, and proximal duct dilated, but distal duct not seen. And in periampullary carcinoma, you will see CBD dilated till lower end. Both PD and CBD are dilated, and the two dilated ducts are almost meeting each other because there is no mass. On the other hand, in CA head pancreas, ducts will be separated by the mass because inside the mass, the ducts are not dilated. Then you look at the cause of jaundice, and you look at gallstones, you look at features of chronic pancreatitis, and you look at metastasis, including liver, lymph nodes, ascites, and large peritoneal or omental deposits. And you also look for changes to suggest secondary biliary cirrhosis or portal hypertension, hepatomegaly, and collaterals. If you're doing Doppler, you can assess the vessels also. CT versus MRI, a general statement, a very general statement, there will be exceptions on both sides, is that for lower end block, that is periampullary and pancreatic head cancer, most people will go for a triple phase or a pancreatic protocol CT. Whereas for higher blocks like hilar cholangio or gallbladder cancer, if you have good MRI, MRI with MRC and MRangio, as Dr. Kishore pointed out, is preferred by more and more groups. And PET CT in gallbladder cancer, more and more evidence is coming in favor that you should do head pancreas selectively based on the size of the tumor and the level of tumor marker. Hilar cholangiocarcinoma, most groups probably would not do a PET CT. So students, please send me a mail, vkkapoor.india@gmail.com. Write SOJ, malignant SOJ in the subject of the mail. I'll be happy to send you the chapter, which also contains a little bit of information about Hilar cholangiocarcinoma. Thank you. Thank you.
Thank you, sir.
Yeah, thank you, Dr. Kapoor. Dr. Shastri, Dr. Supe, any quick comments?
I think, the very nice discussions, Sadiq. Only one comment I wanted to make. Sometimes I think the MR or CT underestimates the grade of hilar cholangiocarcinoma. So many times you should do rotational CT or rotate the whole thing to find out whether sometimes you may say it's stage 2, but it might be stage 4. I think when you rotate it, you probably understand the stage much better. So I think you should really evaluate that way. That's the only comment. Otherwise, it was a very nice.
Yeah, I think evaluation on the console with the radiologist with in all views, and the worst view to be taken as the most probable
Yes,
status of
absolutely
disease.
true. That's what I wanted to say.
Yeah. Dr. Shastri? Dr. TD?
Good morning, sir. So, only thing I want to say about repeatedly you have highlighted Kishore also and Dr. Supe also that at this age, at this stage, the Sanjam cannot say that I like a CT scan. We have to go to the console. Nowadays, all these hilar cholangio and even CA gallbladder, where we have to look into all the vessels and go to the console, sit with the radiologist, and then rotate the films and do a recon, and then only we can take this patient for the surgery. So this is very, very important that MR CP, I think, should have been the first investigation. And MR angio, we have to talk to the radiologist. They need a little bit of more software, and then they can do. It takes a little bit of more time. That's all. And then all the features which are found in the CT scan can be seen, and better enhancement of the tumor in the common bile duct is seen on MR than the CT scan. That is one. And second is in certain hilar cholangio, we also need to do staging laparoscopy. So I think that is one point has not been discussed. Probably based on the CT and MR, whatever things have been done. And then functional assessment of the cholestatic liver is also at some point of time has to be discussed, because only anatomy and volume may not be the most appropriate thing. And many centers do ICG, and they do expect do some site of FIDA and with combined with expect to see the functional assessment also. Thank you.
Yes, sir.
Shastri, any
Yeah,
quick comments?
I think it's a good discussion. Sanjay, you have done well. I just wanted to mention one particular point, say jumping to a discussion of surgical options, before you prepare your ground, based only on ductal anatomy and involvement, before you assess the vascular involvement and the performance status. Be careful of such slips. I'm sure you didn't mean to, but then, in an exam, you don't have too much time to go back. That's otherwise it's a good comprehensive discussion.
All right, thank you. Pradeep, any final thing?
Yeah, I think you have done well, Sanjam. The only thing is, in India, the periampulary is more common than CA pancreas, unlike the West, that you should be aware of it. When you are putting a diagnosis at the end of the history, you don't have anything to go by. I think statistically you'll be writing periampulary at the top of the list. The other thing is, when Kishore asked you LFT, I think you took so much time to interpret the LFT. See, these are the basic things. See, you have to decide whether it's an obstructive element, whether there's evidence of raised OTP is probably hepatocyte damage secondary to cholangitis, or you say whether it's an obstructive pattern saying the ALP is high. And then you said why albumin is low. The most important is, I know nutrition is one factor, but here synthetic functions is what you are looking at. Whether your hepatocyte synthetic function is what albumin and the INR reflects. So these are the basic things. So you have taken so much time on interpreting the LFTs. In the exam, you have very short time. So you should reach quickly to the management strategy. So these are the basic things. You should quickly pass it off by answering these. These are all standard questions. And I think I've been hearing this so-called I'm more comfortable with the CT scan. I think Sadiq has highlighted this has been going on for many years now. I think MR has come so many years back. I think we are very ahead into MR, and now people are moving to MR as the mode of investigation nowadays because you get all the information, including the ductal anatomy. Now they are getting volumetry, even vascular also. I think you should all of you should be more comfortable in reading MR. You can't get away in the exam saying that I'm more comfortable in CT. So these are some of the comments. Otherwise, you have done well. And again, same thing when I don't know who has asked Sadiq or Kishore the PET CT. You kept on saying whether he asked you, do you want to do? The question is, do you want to do or not? So this is very common in the exams also. When a question is asked, do you want to do or what do you want to do? You wanted a one-word answer, what do you want to do? Then you can justify why you want to do or why you don't want to do. So that'll give should be a short and sweet answer. So you want to communicate, so that will give the examiner that you know the subject. Otherwise, at the end of you have spent almost 2 minutes, and Sadiq had to come back and ask you, do you want to do or not? I think you should be very careful in your listen to the question, take a couple of few seconds to frame your answer and answer. So this is for all the exam going students.
Yes.
Okay, Pradeep, shall we close?
Yes, sir. Yes. Thank
Okay.
you, Sanjay. Thank you, Professor
Thank you, sir.
Sadiq, Kishore, and Rohit, and thank you all the other faculty.
Thank you.